Awesome. Well, thank you very much. Let me just jump right in. So let me start by talking about two different types of studies and seeing how we could bring them together. First, let's talk about medical studies, medical device studies, actually. So medical devices are extremely useful as they have greatly improved our healthcare delivery methods. However, medical devices come with their own set of problems. And research that has been done by people in this community, and probably people sitting in this very room right now, has shown that medical devices can be hacked. They can be accessed by attackers. OK, so now let's talk about the other set of studies I want to tell you about, which is enterprise studies. Now, enterprise studies are also extremely useful as, as they give us the security posture of the devices inside their enterprise ecosystem. Essentially, they tell us how devices are working inside their enterprise. And we also know that these devices are useful because, well, we have a whole session dedicated to enterprise security this year at NDSS. However, we don't really know much what happens when both of those studies combine together, when they merge. Essentially, what I'm talking about is a hospital system. So today's keynote highlighted that hospital security is important. So in this case study, we did a case measurement study on a hospital system, a hospital network. We wanted to see to what degree these medical devices were being Sorry. OK. So I can continue if you want, at least for partly of it. All right, then. So how's everybody doing today? How's the first day treating you? OK. Guess I can talk to it for now. Yeah. OK, sounds good.
Anyone know a joke that lasts for 2 to 3 minutes?
Next time, just flip the TV over here. Yeah. That happens. Oh, kind of, sort of. Almost there. All right, well, I can start. So we wanted to see to what degree these medical devices were being exposed. And we also wanted to check the health of their overall operational ecosystem. Because as anybody can tell you, knowing that a vulnerability exists and exploiting said vulnerability are two different things. However, while network studies have been useful in many different enterprises, performing such a study on a hospital requires special care, as they are host to unique data types, and also because any unscheduled downtime to hospital devices can cause life-threatening situations. So what do I mean by this? Well, to give you some insight into the previous slide, I need to talk to you about the design process that we went through, and also the challenges that came along the way. So a hospital network can be seen as an enterprise study. However, traditional tools used for enterprise studies, like probing or active analysis, may not be feasible in a hospital network. While active probing can tell us a lot about the services that are running on the devices or the configuration of the device itself, active probing could also knock devices offline by mistake. So in the case of a hospital system, probing there's a non-negligible chance that the probe device could be taking care of a patient's vitals or be taking care of medical treatment for the patients themselves. So bringing down devices would be problematic. Now, inspecting packets can also cause some issues because In a hospital, the packets may have private data. Private data which has specific legal requirements as to who can actually access that data. For example, only doctors can access your medical records. Now, why am I saying this? Well, for our work, between the loss of data protection and the potential harm that could come from unscheduled downtime of medical devices, we didn't have the luxury to have these unclear boundaries. And that line of thinking actually became the basis of our work. As you can see, designing a hospital study requires clear ethical considerations in order to assure safety and to minimize the potential harm that could come to anybody involved. So for the ethics of our research, we didn't just get IRB approval, but we also involved legal teams and IT teams in order to actually check what was feasible. That way, we had clear boundaries set up, and there was no ambiguity in the ethics. And in the paper, we document this process so that other researchers can use it as another methodological tool. And also so that we can aid researchers that are working in they're working with data where simply accessing the data or processing the data might cause a potential harm. So, 1 second. Sorry. So essentially, this process for us took 2 years of lengthy discussions between all teams in order to figure out what was actually feasible with the study. And at the end, we had 2 different specifications that we needed to meet, and that we needed to meet in order to do this research. And in the paper, we include many more details as to the very careful steps that we actually took in order to assure that these legal requirements were, one, were satisfied in an ethical fashion, all stakeholders could agree on, and that there's no harm coming to anybody. So essentially, the first specification that said that we couldn't collect any data that may have private information from the patient or the hospital workers. This told us that we couldn't collect packet payloads, peer-to-peer traffic, HTTP traffic, or DHCP, as any of those may contain private data or may allow us to actually track hospital workers throughout our collection period. Now, the second specification made it so that whatever we do does not disturb the daily operations of the hospital itself. Essentially, this made our study strictly passive. Here, we couldn't use any active analysis tools like probing or Nmap. And while the hospital can and probably does do active analysis on the devices inside their network, adding more traffic to the hospital ecosystem may have unintended consequences, like bringing devices offline. So it came as a request from the hospital and an explicit decision from our end to not add any more traffic to the ecosystem. And finally, since this is the first study, we need to have some agreement with the hospital. Now, while we can tell you that this was a statewide multi-campus hospital system that we looked at, we can't tell you the actual identity of the hospital itself. And one point that I want to put across here is that this study is all about building trust. At the end of the day, the hospital let strangers look into their network, and us as the strangers needed to abide by the rules they set forward. So as you can see, the design process definitely did limit our ability to conduct our research, but we believe it to be an absolutely critical component since it puts safety and privacy on top of anything else. So now that we know the limitations imposed on us, we can start looking at what we actually collected and the actual hospital itself. So for the hospital, in order for us to collect our data, the hospital staff placed a data collection aggregator at the trunk that connected the hospital network to the rest of the internet. That way we could watch all ingress and egress traffic of all devices. Now, as a side note, hospitals tend to offer free Wi-Fi to their patients. However, that traffic was actually routed through a completely different physical network, so it wasn't actually part of the hospital network itself. Now, a hospital contains many different devices, some for patient care, some for HR, financing, accounting, whatever it may be. But here we have to start making a little bit of a distinction between all the devices. You see, on the top, we have medical devices. And these are the ones that are in direct contact with the patients, and also the ones I briefly talked about at the beginning of the presentation. And in the bottom, we have medical supporting devices. These are the ones that also aid in patient care, but do not necessarily come in contact with the patient. So here we're talking about desktops, tablets, databases, terminals, so on. And the reason why we're making this distinction is because we noticed that traffic coming from medical devices was protected and was actually tunneled through other internal devices like gateways that had extremely limited visibility both internally and externally. Additionally, medical devices, while they're networked, they might not necessarily be in an IP network, so they wouldn't be addressable. And as a result, the traffic coming from these medical devices actually came from these data fusion points. Conversely, medical supporting devices do not have to go through all of this protection mechanisms and actually create the bigger exposure to the hospital itself, and actually became the vast majority of the data in our data set. Now, we collected data from the hospital from DNS requests, established TLS handshakes, and certificates for 6 months from the beginning of January to the end of June in 2018. Now, while this data is useful, we also need to have something to compare it against. So we also crawled other open source intelligence in order to contextualize the results that we get from the actual hospital itself. Now, with the limitations imposed and the data that we collected, we're able to answer two very important questions about the hospital system. One, it's who the medical supporting devices are communicating with, and two, how they're establishing this communication channels. Both of these questions are important as they allow us to measure the health of the hospital without actually going through it on a device-by-device basis. So let's see how the hospital actually looked. So one of the first things we wanted to do was check who the medical supporting devices we're communicating with. And we found that about 64% of the traffic can be automatically whitelisted by simply using the top 100 domains of the OpenDNS. Furthermore, we saw that 0.01% of all requests were actually related to blacklisted activity. And of those, there was about 5,500 requests that actually appeared to be related to botnet activity, either from Zeus or Feodo. Now, this request actually had 2,000 unique domains that mapped to 37 different IP addresses. So we definitely did see some type of domain flux happening. Now, we informed the hospital staff about this activity, but we didn't get any additional feedback regarding this. And this leaves about 35% of the traffic without having any type of category. So we further put another self-association metric that essentially uses the reputation of the second-level domain as a way to whitelist traffic. And we were further able to categorize a grand total of 80% of all traffic. However, the other 20% needed to be manually inspected. And while we talked about that in the paper, here's what we got from the insights from it. And that is, while we found out that medical supporting devices are connected to the internet, hospitals can benefit from having customizable whitelisting and blacklisting techniques, because manually inspecting 20% of the traffic is not a scalable solution in a hospital network. So now we can start. Now, if we look at the TLS traffic, we can start answering the question of how these medical supporting devices are communicating with each other. Here we saw that the vast majority of traffic was actually outbound, meaning that medical supporting devices were the clients, and about 87% of all the traffic can be considered secured based on the protocol that they used. And here, secure means TLS 1.2 or higher. Now, we did see TLS 1.3, but as a reminder, during our collection period, TLS 1.3 was still being drafted, so we didn't really see that much. However, just looking at the protocol doesn't tell us the full picture, because it's still possible to make a compromised channel without actually, by using weak cipher suite. So we further drilled down the data and categorized the cipher quality of each one of the connections into 4 categories. We explained the categories on the paper, but essentially we found that over half of the traffic had absolutely no problem, while the next highest category was insecure, mainly due to the recent deprecation of SHA-1. So here we saw that the communication channels established by the medical supporting devices mostly followed good cryptographic practices. Now, as part of checking how these communication channels are being established, we also looked at the hash functions that were being used on a daily basis, because that can tell us how the medical supporting devices were actually authenticating the other endpoint. And here we saw a few interesting things. First, we can see that MD5 is almost universally gone, both from the hospital data set and our baseline. And as a reminder here, our baseline is the census data set. Next, when we looked at the secure hashing of the hospital compared to the census baseline, we saw that the baseline has on a daily basis had 62% of their traffic authenticating securely, while the hospital had a 10% increase over that. Now, we predict these values to be higher once SHA-1 is being phased out, but when we checked for a decrease of connections with SHA-1, it appeared to be stationary throughout our whole collection period for both the baseline and the hospital data. And here, we can basically say that the secure authentication of endpoints is more common in the hospital than the baseline itself. Now, remember how I said that I couldn't do any active analysis? Well, that's still true, but that doesn't stop us from inferring some partial configuration of the devices themselves. Essentially, simply put, if there's a connection that's been established, then the device is configured to accept that protocol during the connection. So while we saw that the vast majority of the traffic used TLS 1.2 or higher, both in inbound and outbound directions, we saw that 50% or more of the devices in both directions appear to accept TLS 1.1 or lower, which can be problematic since that means that they could accept insecure connections. We wanted to see if these devices accepted this throughout our whole collection period, so we kept track of the last time the deprecated protocol was being used for each device, and saw that in the last 2 months, there was a lot of updates happening for the devices. It actually meant that there was a lot of updates happening for the devices, or they were no longer receiving requests to establish connections with a deprecated protocol. But we also saw the long-lasting medical supporting devices appear to not update regularly, because there's some devices that accepted insecure protocols from the very beginning to the very end of our collection period. And lastly, we also wanted to see the certificates that passed through our hospital network. And about 9% of all the connections reported some type of issue regarding certificates, whether that be the certificate not having an issuer, being self-signed, or having expired, or being expired. All of them are problematic since they essentially bypass the security goals of the whole PKI. And in regards to transparency, meaning how transparent the hospital is to the rest of the world, we checked all the hospital-owned certificates, and we checked them to see if they were part of the Certificate Transparency Project, and saw that about 60% of all of those certificates could actually be found in those logs. But when we checked the actual transparency of all their top services, in Alexa, we saw that they usually got 90% or higher. So here we saw that the hospital adoption of CT is slower than the rest of the top services in the internet. Now, we weren't expecting them to be at the same level, but 60% seemed a little low. Now, this is a measurement study, so it's a snapshot in time. So there's a lot of things that we're not going to be able to see that may be issues for a hospital. So things like passwords getting compromised or misplaced end devices are things that we couldn't see from the limited view that we had. Now, the takeaways of this talk is that our research is the first academic study that considers the real-life operation environment of hospitals and also points out potential issues faced in the ethical design process. Our goal here wasn't just to analyze the hospital network, but to also characterize what we saw. And the work shouldn't end here. Just to reiterate what the keynote said earlier, hospital security is important. And our work should be seen as a starting point for other researchers to do a more broader examination into the hospital environment, as we have shown as we have just shown that it is possible to do this in an ethical manner. With that, I'd like to thank everybody for coming and open the floor for questions if there's any time left. Thank you.
If you have a question, please step up to the microphone, introduce yourself.
Hello, Stanislav Mišković, Splunk. Is this working? No?
I can't hear it.
Okay, so I have a question. You were in the beginning separating life supporting devices and medical supporting devices, but the distinction didn't come through in the results. So when you say that, for example, that most of these medical devices are client devices, what are they communicating to? Or if you say that there is 20% of the traffic that you don't know what it is, what was it?
So the vast majority of the traffic set here was actually from medical supporting devices. We saw very little from medical devices because the data coming from them were actually coming from these aggregation points that were mostly internal traffic. And from the network perspective of egress and ingress traffic, we couldn't really see that traffic much. So this was more from the medical supporting device point of view.
Yeah, sure. But if they were clients, what were they clients of?
Sorry?
Most of the traffic was outbound. Where did it go?
Where did it go? It went from antivirus stuff to, let me recall correctly, normal like Netflix, Facebook, stuff like that. And also a lot of services used by hospital itself. I can't recall the full list. That's actually on the paper.
Okay.
We put the list in the
that
paper.
would be good to see. Thanks.
Yeah, no problem. Thank you.
Hi, I'm Sung Choi at UCF. I really enjoyed your talk.
Thank you.
Because I do research about hospital data breaches, so it was very relatable. So about your research moving forward, what do you propose to health systems and hospitals about mitigating their risk of a digital hospital-acquired infection?
So that's a great question. Hospital research is multidimensional. We just saw one dimension, the hospital network dimension. While we were doing the hospital studies, we also kept track of the data breaches happening to all the hospitals around, and saw that a lot of the data breaches also included access control problems, like password managing, theft of devices, stuff like that. So we need to look into other dimensions inside a hospital, inside the hospital environment to get a framework going.
Great, thank you.
Thank you.
If there are no further questions, let's